When a doctor says you have chronic kidney disease, the immediate fear is that your body is on a one-way, unstoppable train toward dialysis. You picture a creeping, irreversible scarring process, permanently destroying your internal filters. For roughly 20 years, nephrologists faced a frustrating reality. The only reliable tool they had to slow this organ damage was basic blood pressure control. The medical scoreboard for this decline is a metric called your GFR, or glomerular filtration rate. It dictates exactly how much filtering capacity you have left before total organ failure. This chart visualizes the traditional trajectory of a CKD patient. Over time, that GFR line plummets steadily downward, eventually crossing into the red zone where survival requires a dialysis machine. Patients were locked into a passive monitoring cycle. You watched your numbers drop at every checkup, waiting for a cliff you couldn't avoid, rather than actively treating the root cause of scarring. That era is over. Merely trying to slow the train is no longer the medical standard, and accepting inevitable organ failure is an outdated mindset. In the last 5 years, nephrology has introduced medications designed to stabilize kidney function and limit the spread of cellular scarring. Looking back at our GFR chart, the modern medical goal is right here. Instead of a downward slope, doctors aim to branch off and create this line, a zero slope. The objective is to preserve the exact level of organ function you have today. Achieving this zero slope does not happen with a single magic pill. It requires a highly aggressive, staged approach, utilizing multiple medications working together. This is where patients get confused. The most effective new kidney drugs on the market today were actually invented to treat diabetes and heart failure, not kidneys. To protect your remaining kidney function, you have to overcome the hesitation of taking a daily stack of medications that seem like they were prescribed for the wrong illness. You need to understand exactly which drugs fit your specific biological profile. This flowchart is your scenario-matched decision tree to determine which new medication classes apply to your diagnosis. The first universal step begins with RAS blockers. These are medications ending in pril or sartan, like perindopril or telmisartan. This foundational phase requires you to take a daily RAS blocker specifically to lower your systemic blood pressure before that blood ever reaches the kidneys. Your kidney is essentially a biological sieve. By lowering the incoming blood pressure, you decrease the physical, hydraulic stress placed on those microscopic filtering units. These medications are universally effective and highly tolerated. The trade-off is that they only relieve physical pressure. They do not trigger the specific biochemical pathways needed to stabilize the disease. ROS blockers are mandatory for your baseline survival, but relying on them alone means you are using 20-year-old medicine. They are necessary but insufficient for maximum protection. Our flowchart hits its first major fork. Are your filters leaking? By testing for protein spillage, your doctor determines if you move to SGLT2 inhibitors. This phase revolves around Flozins, the new standard of care for chronic kidney disease with protein leakage. Mechanically, Flozins work by blocking a specific glucose transporter inside the tubule of the kidney. This simple action lowers the daily workload placed on your filtering units. During clinical trials, researchers discovered significant secondary benefits. Patients taking Flozins saw reductions in both acute kidney injury and heart failure. If you are not diabetic, this is where you will face mental friction. Your doctor is handing you a diabetes medication, even though your blood sugar is perfectly normal. It is common for a pharmacist or a family member to see this prescription and question if your doctor made a mistake because you don't have diabetes. The medical data is conclusive. There is no risk of hypoglycemia. These agents do not cause dangerously low blood sugar in non-diabetic patients. The medical community has completely recategorized these pills. Cardiologists now deem them heart drugs, and nephrologists deem them kidney drugs. Dismissing a Flozin because it was originally labeled for diabetes will cost a non-diabetic patient their best biological chance at achieving a zero slope of organ decline. We arrive at the final, most specialized branch of the medical roadmap, the diabetic CKD patient. Because diabetes accelerates the rate of kidney scarring, these patients require a targeted add-on phase. This means committing to a third or fourth daily agent. Adding an MRA medication like finerenone blocks a specific aldosterone pathway in the kidney. In trials, this yielded an extra 15 to 25% reduction in cardiovascular mortality and kidney decline compared to a placebo. Then there is semaglutide. In a recent trial of type 2 diabetics with high protein spillage, this medication cut the decline in kidney function by 50%. The barrier here is access. Unlike the universally prescribed Flozins, these targeted add-ons are currently restricted by clinical criteria. You generally need a confirmed diabetes diagnosis and specific insurance approvals to get them. Navigating this tier requires a heavy daily input. You are managing 3 to 4 powerful, overlapping medications every single day for the long term. For the diabetic patient, this pill burden is the price of admission. You accept the complexity of the regimen in exchange for cutting your risk of heart attacks and dialysis in half. This scorecard takes the medical science we just covered and translates it into 2 actionable checklists you can take directly to your doctor. If you are on the non-diabetic route, your baseline stack consists of 2 pillars: your blood pressure meds, the RAS blockers, and a Flozin. You must advocate for this 2-pillar stack and ignore the outdated stigma that Flozins belong exclusively to diabetic patients. If you are on the diabetic route, your stack is built for maximum aggression. You need the RAS blockers, the Flozins, standard lipid-lowering statins, and a strict clinical evaluation for finerenone or semaglutide. Looking at a daily roster of 4 medications is intimidating. It is exhausting for patients who just want a simple fix. But the long-term value of these blueprints is clear. You are trading the daily inconvenience of multiple prescriptions for decades of preserved independence, keeping you away from the dialysis machine. Surviving kidney disease requires navigating modern hospital bureaucracy. Because nephrologists, cardiologists, and endocrinologists often overlap in your care, no single doctor may take the initiative to prescribe your complete stack. Specialists can coordinate to flip meds. A nephrologist can call your cardiologist and swap out an old blood pressure pill for a dual-purpose drug that protects both your heart and your kidneys. To trigger this coordination, you need to use exact language in your next appointment. Ask your doctor, are we utilizing a staged approach, and am I a candidate for the Flozins or finerenone? Medical science finally has the tools required to stabilize kidney function, but surviving the disease requires you to step up as the CEO of your own health and demand the optimal stack.